Hey everyone, so this is the chapter 47 lecture covering collecting the collection, processing, and testing of urine and stool specimens for our clinical skills and procedures course. So we start with medical assistant's role in those two types of specimen collections. The role here for the medical assistant, as it typically is for other types of collection procedures, is to collect, process, and test both urine and stool specimens. Always making sure that we follow OSHA guidelines for handling potentially infectious bodily waste. So as you well know by now, anything that comes out of the body has the potential for carrying infectious disease. So we want to make sure that we are always following our standard precautions and the universal precautions, making sure that you're wearing your personal protective equipment and assuming that everything is infectious and keeping yourself protected from any infectious waste exposure. You want to make sure that when processing urine specimens that you know how to work any of the equipment that may be necessary in doing so. So when specimen processing is necessary, you may need to use a instrument called a centrifuge, and this is something that is also used when we are doing the specimen processing for venipuncture samples as well. And so the centrifuge essentially spins down a specimen and so that it separates the liquid portion of a specimen from the solid portion. And in this case with urine, it will separate the sediment or the solid particles that are typically floating around and naked to or invisible to the naked eye in the urine, but when it's spun down in the centrifuge, they settle to the bottom of a specimen tube. And so when we stick the urine in the centrifuge and it's spun down, it separates the sediment from the liquid portion, which is called the supernatant. And I drew a little picture here over to the side. It looks very beige or white, the sediment does. It's a very small amount, but you'll see they look like solid particles underneath the liquid portion of the urine. So then we pour off that supernatant or that liquid portion of the urine. Usually if you don't pour it off, you pipette it off so that sediment doesn't get mixed back in there with the supernatant. And then the sediment is what is tested underneath the microscope or examined underneath the microscope. And so when the supernatant is removed, you can either flush it down the toilet or mix it with running water down a drain. So that's how that is disposed of. But the point here is to make sure that you know how to work whatever equipment and how to handle the specimens during the specimen processing portion of the testing. So, general collection guidelines for urine. Urine must be collected, stored, and preserved in ways that it won't alter the physical, chemical, or microscopic properties. This is important because most of the time when a urine sample is collected, it's not going to be tested immediately. If it is going to need to be cultured or sensitivity will need to be ran, it's going to have to be sent to a lab that is not on site from where it was collected. So it will end up having to be put into the refrigerator, which we'll talk about under the specimen preservation down here in just a second. But it's important that it has to be collected and stored and preserved in a way that it is going to allow it to be tested appropriately. If the patient is going to be collecting the specimen at home, then they need to be provided with a container and very clear instructions on how to collect the specimen and store it so that it is compliant with the instructions up here in this first step. And then lastly, general collection guidelines. We want to make sure that we are noting any specific time or quantity restrictions. So in this instance, there are some medications that require a urine collection at a specific time because the medications peak at a certain time in the patient's body, or they may trough at a certain time. For other hormone-based tests, or actually a significant other number of tests, a lot of times they'll want the first morning urine because that is the most highly concentrated urine because it is collected overnight. You know, there may need to be a urine sample or a test that is done on at a specific time. Other tests have quantity restrictions, and so, for example, some of the drug screens require a minimum of 20 mils, or some of the other tests may require, you know, 10 mils. Some of the other tests require a full 24 hours of collection in order to get those tests ran. And so if there are any time or quantity restrictions, we want to make sure that we are fully cognizant of those and also explain those to the patient as well. Various specimen types. These are important to know, so make sure you memorize these because you will see a lot of urine specimens being done on patients when you go out to your externships, and then when you begin working. Urine tests are cheap, they are easy to do, and so we see them pretty frequently. So random specimens are the most common type. They are taken at any time of the day, and they are taken in a clean, dry container. Not necessarily a sterile container, it's just a clean, dry container. The first morning urine is going to be the first void after sleeping, and so this is when urine is most concentrated, and so that is when the greatest amount of anything is going to be in the urine. Now, it's called first morning urine if you have a patient who is a third shift worker. Their first morning urine may be at 4 o'clock in the afternoon after they have worked until 7 a.m., came home, went to sleep, and then woke up at, you know, 3:45 in the afternoon. So first morning urine is going to be essentially their first urine after waking up after a long period of sleep. So whatever time of day that is, that's going to be their first morning urine. Clean catch midstream, this one is also equally as important. It is abbreviated CCMS. It uses a sterile cup, and it requires a towelette to clean the external genitalia to avoid contamination by organisms near the urethra. Now, usually there are 3 towelettes that are accompany this clean catch kit, and they come kind of packaged together in a little bag, and it's the sterile cup and then the 3 towelettes that come with it. And so how this works is, if it is a female patient, they will wipe one time front to back with each towelette, and it will be important that if it's necessary that they spread their labia and cleanse just once. They start at the front near the urethral opening, which will be above their vaginal opening, and wipe once front to back. And then they discard the towelette, grab the next towelette, wipe once from the urethral opening all the way back, discard that towelette, and then do the same thing with the third towelette. If it is a male patient, then if he is uncircumcised, he'll pull the foreskin back, wipe once around the tip, and then discard that towelette, do the same thing 2 more times. If he's circumcised, then he doesn't have any foreskin to pull back. He just wipes once around the tip with each of the 3 towelettes and discards those. So it is important that those instructions are made clear to the patient so that way they know how to cleanse properly to avoid contamination, you know, from those organisms near the urethra. So once they have the cleanup done, then the steps are to urinate into the toilet a little bit, and then they urinate into the cup, and then they finish urinating into the toilet. And so it's pee in the toilet, pee in the cup, pee in the toilet. And so the point is to grab the middle of the stream of urine. And so it's excuse me, it's a little bit tricky to do, especially when you're trying to focus on getting it done, and especially for women. I would think, I don't know, I'm not a man, so I've never urinated like a man, but for women it's a little bit awkward because you're trying to hold the cup there and trying to, you know, not miss it, and so it's a little bit awkward, but you know, if they can get as much of it as they can in there, then, you know, we do what we can with it. The last type is a 24-hour urine collection, and that is where the patient is going to collect all of the urine for 24 hours into a jug. And they do that with the exception of the very first urine of the day. Sorry, my grandpuppy is whining in the background and laying upside down very cutely. So they do that with the exception of the very first urine. So they void the first urine, and then after that first urine, they collect everything for a 24-hour period. The patient should be instructed to not collect any stool or toilet paper into the jug. That should be a given. It's urine only, but sometimes, people misunderstand directions. Also very important that they should keep this refrigerated. Now, what I used to tell patients to do when I was giving 24-hour urine instructions all the time was to go get one of those little styrofoam $2 gas station coolers and, put a bag of ice in that and keep it in there if they were creeped out about keeping a jug of urine in the refrigerator with their food. So that way they could keep it with them. Also, too, that works really well if they have to travel for the day or if they're going to be at work for the day and they don't want to really keep it in their work refrigerator. Coworkers aren't really hip with somebody's urine hanging out with their lunches most of the time. So that works really well if they can go pick up one of those little $2 styrofoam coolers, or if they have an old lunch cooler or something that they can utilize and put some ice in to keep it cool, then that works out really well. The 24-hour urine collection serves to measure output and quantities of levels of substances like calcium and sodium and a number of other things. So there's a reason to make somebody collect, 24 hours worth of urine. But those jugs can be quite odoriferous when you open them. Some people will fill one, some people will fill two. Some people will fill, in between that amount. It just kind of depends on how much water they drink and, what their kidney function's like. So, you have to write down the volume and the quantity, or the volume, of those two jugs, or of the jug, when they return it the next morning. And, out of all of the volume, you only end up taking a small amount that is actually tested. So it's kind of crazy. Alright, so moving over here to catheterization. A catheter is inserted into the bladder for a whole bunch of different reasons. The main one is usually just drainage, and that is to withdraw fluids, relieve retention, collect a sterile specimen, measure residual urine volumes, sometimes to obtain a sample from someone who can't void or urinate normally. And then also sometimes we use a catheter to put something in, which is normally chemotherapy, into a patient with bladder cancer. There is a splinting catheter that is used to repair the ureters, which is the tube that drops down from the kidney to the bladder. And you have one of those dropping down from each kidney to connect to the bladder, and so sometimes they can put a splinting cath in that will help repair a ureter if it's damaged. And then the last type of catheter is called a Foley cath, and it is a cath that stays in place. So the other two are removable, and this Foley cath is one that stays in place a little longer. Foley caths are removable too. I don't want you to think that anything is permanently there forever. But a Foley cath is a little bit different in the fact that it's indwelling. So it stays in place. It has two tubes and a bag that attaches to the patient's thigh, and so it's meant to be there for a little bit longer term, and then it's just changed out less frequently. So I think I'm going to do a chain of custody last. I'm going to jump over here to gender considerations. For different gender considerations, I talked about this a little bit over here with the clean catch midstream, but you may need to give different instructions or directions to that are gender specific, and this again applies to things like the clean catch midstreams. Also to the second point here, Pregnant patients will have different considerations when it comes to urine samples. Pregnant women, they tend to go a lot. They may be prone to urinary tract infections. The urine of pregnant women is checked at each appointment for glucose and protein levels, whereas that's not the case for most male patients. So there are some considerations that you need to be aware of when it comes to differences in genders. So just kind of keep that in mind. Specimen preservation, the proper storage of a specimen is going to be essential for obtaining a valid result. Most of the urine specimens are going to be refrigerated because that's going to prevent bacterial growth for about 24 hours. After 24 hours, it's going to have to be pitched and recollected if you can't get the specimen to be tested in that time frame. So just kind of keep that in your mind also, that urine needs to be tested within 24 hours, even refrigerated. But it needs to be refrigerated within a half an hour of collection in order to keep bacteria from growing in general. All right, and then lastly on this page you have chain of custody. It is a process that is used for drug and alcohol tests. So any specimen, urine and blood specimen, that is involved with chain of custody is a legal specimen that can be used in court. And if it's being used in court, it's usually being used as part of a conviction process. So there's a criminal case usually that is, or a custody case. Sometimes it's like a family custody case or like a child custody case or something like that. But there's usually, in my experience, it's almost always a criminal case, like a DUI or drug possession or something like that. So these chain of custody cases are legal specimens that can be used in court, so they have to be handled with like extra care. You have to be super careful in how you process them, how you prep the patient for them, how you collect them. Urine specimens will go in a special sealed transfer bag, and that bag stays sealed after it's been collected until it is opened by the lab to be tested. And there's a whole bunch of paperwork that goes with it. Everybody has to sign off on the paperwork so that it is accounted for step by step from the time it's collected to the time that it is tested. And then there's an additional consent form that goes along with it that allows the patient to self-report any prescription medications that they have taken for up to 30 days. So just kind of know that as well. Okay, so urinalysis is the evaluation of urine to obtain information about the body's health and disease. There is a physical urinalysis, chemical urinalysis, and then microscopic urinalysis as well. So we start with the physical exam, which is going to range from a pale yellow. The physical exam involves looking at the color, looking at the turbidity, and then measuring the volume and the specific gravity. So when we look at the color of urine can range from pale yellow to dark amber, depending on the patient's fluid intake, so how much water they drink, or the type of fluid that they are intaking, and the amount of waste products that are present. Turbidity is the cloudiness of the urine, or how transparent it is. It can be clear, slightly cloudy, it can be very cloudy. Clear is the normal. You should be able to see through urine. It can be urine can have an odor. There isn't typically an odor noted with urine. I mean, urine doesn't smell great, but there should not be like a very strong odor. We don't normally chart an odor, but if there is a very strong odor that is noted, then you can chart that because it can indicate disease or infection. You should keep in mind, though, that there are some foods like garlic and asparagus that can cause a urine odor, so it could just be something that they ate. But if it's something that is truly offensive, then I would chart that, just because it could indicate a disease process or an infection that the doctor needs to address. Volume is another metric that we definitely chart every time when we are doing the physical assessment. It is the amount of urine that is in the cup, and it is a normal volume amount is going to vary with age, so there's not really anything that you need to worry about there. Just chart how much is in the cup. And some terms that you need to know that are associated with urine volume. Oliguria is an insufficient urine production. It is caused by dehydration, shock, or renal disease. Anuria is the absence of urine production altogether, and it's usually due to an obstruction somewhere along the way in the ureter or in the urethra. So there's an obstruction somewhere, or there is renal failure somewhere, so the kidneys aren't doing their job, or there's an obstruction in the way that the urine travels down to the bladder or from the bladder outside the body. Specific gravity is the last of the physical assessments, and it is the measure of concentration of substances that are dissolved in the urine. And it is measured with a tool using a light called a refractometer, or it is measured on the dipped reagent strip. And so most oftentimes, because it's measured on the dipped reagent strip, we don't have to do the refractometer test, but if you are not doing the reagent dip, then you want to make sure that you use the refractometer to measure the specific gravity as well. So speaking of that reagent strip testing, the reagent strip is a form of chemical urinalysis, and it is used to test urine for all of these things. Now, the test strip that I drew model of here is the one that we use in class. It's a McKesson brand test strip, and so these colors aren't 100% accurate. It's the ones that I have available to me on my iPad in the GoodNotes app. So if you are looking at this, then these colors are as close as I could get to the ones that you will see in class and lab on the reagent strip. But the boxes do match up on the strip to what you will see in class on the McKesson strips themselves, and the times that are on the strips are the same. So starting at the top, box number 1, you would read at 120 seconds elapsed after dipping, and actually the way that these reagent strips work, and this is the same for all of them, although, well, this is my little disclaimer, you should always read the manufacturer's instructions for any testing before you do the testing, but generally speaking, the reagent strips are read from the handle upward, and so you can see at the bottom the glucose square. I think that's glucose. Let me go down here and check. Oh yeah, it's over here. The glucose square is read at 30 seconds, and the bilirubin square right above that is read at 30 seconds as well. And then the ketone square is read at 40 seconds. The specific gravity is at 45 seconds. And then from there all the way up to the leukocytes. So blood, pH, protein, urobilinogen, and nitrate are all 60 seconds, so all of these guys here are 60 seconds after it's been dipped, and then the leukocytes are 120 seconds. So this is what I can tell you. Until you get used to doing these, you're going to start reading at 30 seconds, these two bottom ones, and then pretty much keep reading until it hits 2 minutes, because what happens is if you do not read these quickly enough, the colors will start to change and they won't match any of the boxes on the results chart. So on the back of the bottle that the strips come in is where you match these colors up to, and they won't match anything if you let them if you don't read them in a timely fashion. So you're going to want to make sure that you are reading these reagent strips at the appropriate times in order to get an accurate assessment of the correct result level. Okay, so on the reagent strips, starting at the top for the lecture, the leukocytes, which is box number 1, those are white blood cells. They appear in urine in the case of urinary tract infections or renal infections. Moving on down, nitrates are different bacteria in urine that make an enzyme that changes the urine nitrates to nitrates, and that can suggest an infection. Urobilinogen is that could represent an increased level, could represent red blood cell destructions or liver disease. A lack of urobilinogen could indicate total bile duct obstructions. So how this works is that the hemoglobin breaks down, and this is absorbed in the intestines. So this urobilinogen is coincides with the bilirubin down here. So I'm going to jump down to number 9. Bilirubin, when the hemoglobin breaks down, it converts to bilirubin in the liver, and then the bilirubin in blood is the first sign of liver disease. So when we look for it in blood, it's usually the first sign of liver disease, but if it is present in urine, it could also be an indication of liver disease. When the hemoglobin breaks down further and is absorbed in the intestines, it becomes urobilinogen, and then if it is out into the urine in the form of urobilinogen, it can also be a sign of red blood cell destruction, or a bile duct obstruction, or liver disease. So those two, urobilinogen and bilirubin, kind of go hand in hand. So back up to number 4, protein. Any excess protein is proteinuria. That usually indicates a renal disease. pH measures the acidity or alkalinity of a person's urine. Normal pH is 4.5 to 8.0. An average pH level is 6.0. 7.0 is considered to be a neutral pH. If the urine is too acidic, it can indicate acidosis or phenylketonuria. If it is too alkaline, it could indicate a urinary tract infection or a metabolic or respiratory alkalosis going on. If there is blood in the urine, which is box 6, it is hematuria, that is blood in the urine, the medical term for blood in the urine. Could be menstruation, so if it's a female patient, that's always rule number 1, to check to see if they're menstruating. Otherwise, it could indicate a urinary tract infection, some type of trauma or bleeding in the kidneys, the ureters, the bladder, or the urethra. So those are other possible reasons to have blood in the urine. Number 7 is the specific gravity box, and there is information over here to the left that we just talked about. That specific gravity measures the concentration of substances dissolved in the urine. Number 8 is the ketones. Ketones are produced by liver from fat metabolism, and so their presence in the urine indicates a low-carb diet. That's the keto diet that everybody is raving about. It can also indicate starvation, excessive vomiting, diarrhea, or also can be an indicator for diabetes. Number 9 we already talked about, and then lastly, number 10, glucose, is glycosuria is glucose in the urine. If glycosuria is significant glucose in the urine, so it's an excessive amount of glucose in the urine, it is common in diabetic patients. So if a person comes in and they have a high reading of glucose in their urine, then that could be an indicator for diabetes if a patient doesn't know that they are already diabetic. Okay, so other chemical tests that are done on the urine, we have the phenylketones, which indicates phenylketonuria, which is a genetic metabolic disorder. You learned a little bit about this a few lectures ago in the pediatrics lecture. A buildup of those phenylketones results in mental retardation, but it is easily treated with diet. Well, I don't think anything that's treated with diet is particularly easy, but it can be treated with diet to prevent the buildup of those phenylketones, and prevent the effects of phenylketonuria. Pregnancy. The urine pregnancy test tests for the presence of HCG, which is human chorionic gonadotropin, that is secreted by the placenta. The placenta is a temporary endocrine organ, which only is in place when a woman is pregnant. So it will secrete this HCG hormone. The levels of HCG vary during pregnancy, but they typically peak about 8 weeks. HCG typically doubles every other day up until about 8 weeks, where it peaks, and then they start to decrease slowly. We can also test urine for sexually transmitted infections. For STIs, we typically prefer blood, but urine can be tested. It's a little bit more expensive to test urine for STIs, but it is easier to collect because it's less invasive. We don't have to put a needle in anyone. And urine does offer highly specific testing for sexually transmitted infections, just as blood does. It's just a little bit more expensive to do it that way. Alright, so moving on to page 3. Page 3. To the microscopic examination of urine. Some things you need to know over here. We look at cells when we are looking at the microscopic exam of urine. A few different types of cells: epithelial, white, and red. The epithelial cells are typically classified as renal, squamous, or transitional. The renal cells are going to look oval or round shaped. They will most likely have a large oval nuclei in them. And they can, if they are present, they can indicate tubular damage in the kidneys. Transitional epithelial cells line the urinary tract, and their presence may indicate tubular damage. They are also round or oval, but most of the time they will have a tail, and they will have 2 nuclei in them. Some other types of cells that we look for in urine include white cells. Those are larger than red blood cells. They are found in the urine if there is some inflammation going on or some contamination present, so like an infection. Because as we've talked about before in other lectures, our white blood cells are part of our immune system response and our immune army, and so they come anytime there's an infection and try to eat the infection and rid the body of it. So it would be expected that we would see some white blood cells if there was some type of inflammation or infection present. And then lastly, we may see some red cells in the urine also. They can enter the urinary tract if there's an injury or inflammation present as well. And so one thing we look for when we see red cells is if there are more than 3 red blood cells per high power field, then that is something that will cause further testing to be done, because having more than 3 red blood cells per high power field on the microscope can be an indicator for a whole host of other disease processes or illnesses, or like a whole variety of problems. So that will be catalyst for further testing. Okay, so other things that can be floating around in the urine, we have casts. Those are cylinder shaped, and they have flat, rounded ends. They form when proteins break down, when the protein breaks, I don't know why I can't read this. They form when protein from the breakdown of cells accumulates and precipitates in the kidney tubules, sorry about that, and then it is washed into the urine. So when the protein from the breakdown of cells, the cells break down and the protein from that process builds up and kind of gets stuck in the kidney tubules, and then it's washed into the urine. The protein then assumes the shape of the tubule, so it takes kind of like the form of the kidney tubule. And when it's flushed out into the urine, you can see that it is like kind of a tubule cylinder shape, so it kind of looks like a straw shape, if you will. There are several different types of casts. There are hyaline casts, there are red blood cell casts, waxy, granular, and epithelial cell casts. So there's a lot more information in your book about those. I'm probably not going to ask you a ton of questions about those because we have excellent lab technicians that do a lot of the microscopic exams. MAs don't typically do a lot of the microscopic exams, but it is good to be knowledgeable about what is normal and abnormal in urine samples. Crystals are another thing that can be floating around in patient urine. Crystals are naturally produced solids of definite form. They are commonly seen in urine, so they're pretty normal. They usually don't indicate any significant disorder unless they are found in very large numbers in patients with kidney stones, patients who have hypercalcemia, or patients that have an inborn error of metabolism. So unless the patient has one of those things, where they have a lot of kidney stones, they have a hypercalcemia error, or an inborn error of metabolism, then we don't really worry about crystals too much. Yeast cells, we can see those as well. They are typically associated with genitourinary tract infections. They sometimes are there not because there's a UTI going on or anything like that, or an external an external tract infection. Sometimes they're there because they were picked up from external genitalia contamination. They can be there from a vaginitis or urethritis infection, or they can even be there from prostatitis. So yeast cells are commonly seen in diabetic patients' urine because diabetic patients have a lot of yeast infections, and so we can see those pretty often. Bacteria. A few bacteria in the urine are okay. It's to be expected, but many bacteria in the urine can be a urinary tract infection. If many bacteria and the white blood cells are present together, especially with a putrid smelling urine, then that's probably definitely a urinary tract infection, and it's probably going to need to be treated with antibiotics to get that cleared up. Parasites if a parasite, I keep flipping this forward. If a parasite is present, it may signal genitourinary tract infection, or again, it could just be external genitalia contamination during the collection process. The most common parasite picked up in urine is Trichomonas vaginalis, so we see that pretty frequently. For the microscopic examination of urine, the test that is most commonly done is called culture insensitivity. It is abbreviated as C&S. If a patient has a suspected urinary tract infection, or if bacteria has shown present in a urinalysis, then a urine culture is most often performed. In order to obtain an appropriate specimen to perform the urine culture, a CCMS or a clean catch midstream specimen is usually required. And so what will happen is we will get the specimen by way of clean catch midstream, and then we will take a sample of that clean catch specimen and send it to the lab. They will take a small dip of that, plate it onto a plate of agar, and culture it and grow whatever it is that is in that urine in a couple of different methods. And then once they can identify the bacteria that is growing in the urine by way of culture, they can do what is called a sensitivity, which is the test that they perform to help them select the antibiotic to inhibit the growth of the bacteria. So once they can identify the bacteria, then they can do a sensitivity to know what antibiotic is going to kill that bacteria, essentially. So that's what culture insensitivity does. Alright, so page 4. I just realized I have an old leftover page in here from an old lecture. Sorry about that. So page 4 is the last page for this lecture, and it covers stool specimens. So we got a lot of stuff for urine and only one page for stool, so that's fun. Stool specimens, we cover a few things here. The first one is the fecal occult blood test. You guys are doing these in class. And the fecal occult blood test tests for blood in the stool that is not visible to the naked eye. The presence of blood in the stool may be an indicator for colorectal cancer. These tests are fast, they are easy, they are extraordinarily inexpensive. I mean, they're super cheap to do, and they may also be used to determine the cause of anemia. So these tests are also known as Hemoccult. In class, you'll hear me call them Hemoccults a lot. I think that may be a brand name for them, I'm not sure, but Hemoccult, occult blood tests, it's all the same thing. These tests are super cheap, they are easy to do. Let me rephrase that. They are easy to do for us in the lab. It's just a couple of drops of the controls over the back of the filter paper on the sample slide. You can watch the video that I put up on YouTube for that. Like I said, you're going to do these in class. For the patient, it's a little bit more difficult to collect them. There are specific instructions that need to accompany the slides to the patient so that they know not to eat red meat, that they know that they have to collect usually 3 samples on 3 different days for 3 consecutive bowel movements, and that they know that the samples need to not be contaminated with toilet water, that it needs to not be contaminated with tissue or with urine. And so that tends to be the biggest pain point for the patients, is to not let the stool sample be contaminated with urine, because if you're a female, you urinate, actually most people, but definitely it's harder for women, you urinate every time you have a bowel movement. So, and it's hard to kind of separate those two areas. And so it's difficult. One trick for that is if you work in a lab or work at a facility where you can give a patient a urine hat, then to have them sit the urine hat backwards on the toilet so that they can collect the stool specimen into the urine hat, and that way when they urinate, the urine will go into the toilet, but the stool specimen will go into the hat, and then they can, collect for the Hemoccult card from that specimen that was collected in the backwards urine hat. So there's a whole bunch of other methods to catch the specimen, but the point is to make sure that it doesn't get contaminated with toilet water or with urine or tissue or anything else. So you can check your book for more details on that. It's a good time. And I know you guys are pretty excited about doing those in class too. Bacterial infections of stool samples. Infections can be caused by species of Shigella or Salmonella genus, and those can cause loose, bloody, or mucousy stools. If that's the case, if a patient comes in and they've had diarrhea for a long time, this happens a lot. One of the first questions they'll be asked is, have you traveled outside of the country? And if that's the case, then they're definitely going to be ordered stool cultures to identify the bacteria. Even if they haven't traveled outside of the country, they're probably going to be ordered stool cultures to identify bacteria. We just want to make sure that they don't have any kind of bacterial growth growing on inside their intestines that are causing these. And then lastly, protozoa and parasitic infections of the intestines that can cause bowel issues. You have ova and parasite kits that test for an infestation. These are usually, I put a picture of an O&P kit here. It's usually ordered for 3 times, so it's to be done on 3 consecutive days, much like the fecal occult tests are done. These O&P kits are done for 3 consecutive days. They look kind of like this. Usually, sometimes some of the kits will just be the orange and the pink one. Sometimes they are orange and blue or pink and blue. I think the gray one over here is actually for the stool culture sample, because most of the time, if they're doing an O&P kit, they assume that they're going to try to identify whether it's a a protozoic or a parasitic infection, or if it's a bacterial infection. So if they have you collecting stool samples, they're just going to test it all. And so what happens is most of the time when people are collecting these types of samples, the patient has diarrhea, and so it's liquid, and so or the stool sample is very loose. And so if you open up the caps of these, they have little spoons or little scoopers in them that are stuck to the lids. And so they just scoop a little sample and they put it down in there, and then they close the lid back, stick it in the biohazard bag, and then they bring them back. So these have to be brought back to the lab shortly after collection. So they do this for 3 days in a row. They bring them back to the lab every day, and you know, then the lab starts to test them. So these are super fun to do also. Okay, so I think that's it for this, because this next page is a random page from our otology lecture last week or the week before, so sorry about that. If you have any questions, let me know. Otherwise, I think that's it. Thanks, everyone.